Before I get started, let me give you a little bit of a background of who's speaking with you and where I come from. I grew up in Michigan and went to University of Michigan for undergrad. I did medical school out in Ohio as well. I'm an orthopedic surgeon and I trained in both Los Angeles and Pittsburgh. And before I made my way out to Corvallis, I was actually in practice in the Dallas, Texas area, where I worked at the big medical center there, the University of Texas Southwestern, as well as some time at the county hospital, which is one of the highest volume trauma centers in the country, as well as the Veterans Hospital in the area. My training, I'm a orthopedic surgeon, and I also have a second board certification in sports medicine. That makes me a subspecialist in sports medicine. My background during my training, I worked with professional and college sports teams in Pittsburgh, including the Penguins and Steelers. And currently I work as a consultant as well for Oregon State University Beavers Athletics. Some of kind of my philosophies with care. I think a big thing is, particularly in sports medicine, every patient has very individual needs. And I think it's important to treat people as individuals. Not every knee injury is the same, even if the MRI might be similar. We all have kind of different things that we want to do in our life. Some of us just kind of want to get to our day-to-day jobs, and other people have very high demand athletic activities. So I think it's important to treat people as individuals, and that's all the way from, non-operative treatment options to different things we can do surgery and kind of everything in between. So, tailor all of these things based on any individual's unique needs. So this talk is basically an overview of some of the more common sports injuries and what we can generally do about them. We'll begin with ACL. I think that has a big interest both in it being a very common injury for us to personally experience, as well as something that we'll often see if we're interested in watching collegiate or professional athletics, because this tends to be a fairly remarkable thing that happens to a lot of athletes, and a lot of individual teams fans will notice that often players will all of a sudden be out with an ACL injury. So about 400,000 ACL reconstructions are done annually, and its mechanism is actually not usually a contact injury. It's actually usually a non-contact injury. Symptoms that people have when they have an ACL tear is often people will feel a pop in their knee. It's generally quite painful. You're not usually able to continue with the activities that you're currently doing. And usually your knee will swell up pretty substantially after the injury. People who are at particular high risk are those who participate in pivoting sports like soccer, football, and basketball. Skiing is also a very common sport that people can injure their ACL, because your foot's stuck in that ski boot, and if you catch your ski on the snow going down the hill, your whole knee will be what rotates when it kind of catches, not so much your ankle. Additionally, we found that female athletes are actually at a substantially higher risk of ACL injuries, and that's both based on anatomy, and that females generally have a little bit wider hips than their male counterparts, as well as some of the kind of mechanics that are more commonly found in females than males. As far as treatment goes, this can really run the gamut. People who might have a low sporting demand might elect for non-operative treatment. A lot of patients who tear their ACL can still run. I've treated marathoners who ended up treating their ACL injury non-operatively, who went back to running marathons. You can still do workouts at the gym, but you just really struggle to do pivoting activities. Some people, even with low demand, so even daily activities of living, their knees might still be unstable, and they might not be able to cope well with an ACL deficient knee. And some of those people might be a little bit more loose jointed in general. And a successful candidate for non-operative management generally won't have instability with those daily activities of living. So getting in and out of your car, turning around in the kitchen to go to the island, things like that. More commonly than not, though, ACL injury does require a surgery. In general, also, that's going to be a reconstruction. So it's very unlikely that we're able to repair ACL injuries. Historically, that was what was done, and it did not do incredibly well, but there's some experimental techniques that are still kind of early on in their development So maybe something in the future to look out for. But currently what we do now is we take tissue from elsewhere to make a new ACL, and that might be tissue from your own body, or it might be actually even tissue from a cadaver that's been donated to help reconstruct you. So how do we fix the ACL? So again, we use tissue from elsewhere. So we call it autograft if it comes from your own body, and cadaver graft is called allograft. Generally, young patients and highly active patients in pivoting sports, we highly recommend tissue from your own body because cadaver graft could have a higher failure rate in that population of patients. And this is an example of an MRI scan of a patient who has an ACL tear. So there should be a nice ligament that goes from the tibia bone here to the femur bone. And we see that that structure has been disrupted, and there's some white, which is swelling where the tissue is disrupted. And this is an example of an MRI after the ACL has been reconstructed. So we see the new ACL graft. In this particular instance, this is a quadriceps tendon autograft. But the point is that you now have a ligament that's reaching from point A to point B, so from the tibia end of the femur, giving that patient stability again. So generally, when we're talking about tissue graft choices from our own body, there's three options, and I generally will offer patients any graft that they ultimately elect. They all have pros and cons because we're robbing Peter to pay Paul in some extent. So quadriceps autograft it obviously comes from your quadriceps tendon. The re-tear risk is pretty low. It's about 5 to 7%. It has a low risk of re-tearing. Some patients with quadriceps tendon grafts will struggle a little earlier in their physical therapy progress to get their quadriceps strength back, but they generally will catch up at about 4 to 6 months after surgery. Patellar tendon is a very common graft in high demand elite athletes. This is probably the most common thing that we see in NFL players or collegiate football players. And part of that is because in order to get a patellar tendon autograft, we take a piece of the patella bone as well as the tibia bone, the shin bone, along with the patella tendon itself. When we do that, we can have that piece of bone incorporate into the little sockets that we make in the bone, and it might remodel a little bit quicker. So when we talk about high demand athletes of trying to get back to their sports as quickly as possible, even 7 or 8 months after their injury, we want that graft to be as mature as possible. So that's kind of the upside to it. The downside is oftentimes people with patellar tendon autografts will have some difficulty kneeling on their knee. So if you know someone who has this graft, they might not want to kneel directly on the knee. And it might not be a great choice for someone who might be like a carpenter or maybe a wrestler or someone like that who might be on their knees a lot with their daily activities. Hamstring tendon is also an option. It's a soft tissue graft as well. We found more recently that it might have a slightly higher re-tear risk, particularly in high demand young women. Those athletes might have a higher risk of hamstring tendon injury, and it also has the downside of having a permanent defect in the hamstring strength compared to what it was beforehand. For that reason, I generally don't do a whole lot of hamstring tendon grafts because the other grafts tend to perform a little bit better. But some people have had a hamstring tendon done on the other side or have a family member who had a lot of success, and overall, like it does do pretty well and has a good track record. As far as what that looks like, these are arthroscopic photos of each of those grafts, and you can see they all look pretty similar when they actually get in your knee, and they all ultimately perform pretty similar long term. Some kind of cutting edge things that we can do to decrease risk of re-injury in some specific patient populations. So we found that young patients, people who do pivoting sports, people with hypermobility or previous failed surgery might be at higher risk of failing even a second ACL reconstruction. So people with some of these risk factors, we might recommend an additional procedure where we take some of the tissue on the outside of the knee capsule and reroute it a little bit to augment that rotational stability. So, you know, when an ACL tendon or an ACL ligament rips, it's not just the ACL that gets injured, it's all of the tissue, the joint capsule, which also gives you some stability, particularly in rotation, can get stretched out. And this type of a procedure is kind of a cutting edge thing that we've started to do to give people a little bit more stability if they are a particularly high risk patient. The advantage to doing it is it might decrease the re-tear risk and the long-term chance of success of having an ACL reconstruction. The downside is it does require a little bit more surgery and an incision on the front of your knee. And that's something that's, you know, we talk about looking at treating every individual as an individual. That's one of the things that we look at when we're deciding how can we best get you back to your sports and activities and minimize the risk that we have to see again in the future for more injuries. So along with an ACL reconstruction, and much like a lot of the other sports injuries that we're going to talk about today, a big part of the surgery is actually the physical therapy. While it only take us an hour or so to reconstruct your ACL, it can really take patients 9 to 12 months to really make it through rehabilitation. And fortunately, here at the SAM and at Samaritan in general, we have fantastic physical therapists. With ACLs in specific, and in particular, there's kind of 5 phases of ACL rehabilitation, and we start that as soon as a couple days after your surgery. So this is the type of surgery, it's not meant to kind of lay you up and you're not bed bound after surgery, it's meant to get you going again. So the first phase, we really aim to decrease swelling and get our range of motion back. We then move to try to start stabilizing the knee and the whole kinetic chain. So when we say kinetic chain, everything all the way up to the floor to your core muscles are influenced with a knee injury. So we kind of start working on core and leg stability exercises in the second phase. In the third phase, we start working on more dynamic activities. So this is as we start to get back to activities like running and jogging and weight training, as well as to work on balance. As we start to get to phases 4 and 5, we're looking to really normalize movement patterns and develop good habits to try to prevent putting our knee in at-risk positions and also build the strength to be able to safely return to our activities. The other thing to remember is healing and remodeling of the ACL graft itself can really take up to a year to 2 years after surgery. So even after we start returning to sports, people are still at a slightly higher risk of re-injuring the knee, even up to 2 years from the surgery. So it is a long recovery process, but for a lot of athletes, it's very, very fulfilling and worthwhile to make it all the way through. Meniscus injury, so that's probably, I'd assume most people in this room have met someone or know someone who has had a meniscus injury if they haven't had one themselves. So what is the meniscus? It's something that works as a shock absorber. You actually have 2 meniscus in each of your knees, so a total of 4 menisci. And what it does is it kind of works like a rubber band. So it turns that up and down force that occurs when we're weight bearing, and it turns it into a circular stress to offload it, much like a thick rubber band can kind of resist force. So it works as a shock absorber, and it helps offload the cartilage or the lubricated surface of the joints to help protect from arthritis. It also deepens the joint surface and gives you some stability as well. Unfortunately, it's one of the most commonly injured structures, and it's one of the things that we most commonly see patients for in the orthopedic clinic. An arthroscopic meniscus surgery is historically the most common meniscus and orthopedic surgery in general as well, so it's very common. So there's 2 big categories of meniscus tears. There's the tear of a healthy meniscus in an acute fashion, as well as a degenerative type tear. The degenerative type tears are actually classified as a part of arthritis, whereas the acute meniscus tears are generally something that happen in otherwise healthy knees. So which types of tears can we repair and do we do surgery on? Generally, the acute tears in healthy meniscus are the ones that we can repair. So the thing about meniscus is it actually has a good part of the meniscus that can heal and has a good potential to really remodel, and then it has a part that does not get a great blood supply and may not heal particularly well. So some of these tears that do well with repair are in the well-vascularized area of the meniscus. You might have heard of a bucket handle tear of the meniscus, which is when nearly the whole meniscus basically avulses off of its attachment to the outside of the knee and flips into the middle of the knee that can prevent range of motion. These tears can be repaired arthroscopically, and often if we have those type of tear patterns, we'll generally recommend surgery, as this structure is very important in the long-term health of the knee. Patients who don't have their meniscus repaired or have their meniscus removed have a very high rate of developing arthritis in the short-term future. So we generally say, when in doubt, we always try to repair the meniscus. Sorry, I went backwards. So degenerative meniscus tears are a little bit different of a story. Oftentimes, surgical management is not generally recommended. The only times we'll generally move very aggressively with surgery is if the range of motion is blocked, or if there's a reason to restore or there's a reason to think that we're able to restore and repair the meniscus. In fact, generally people don't always get MRI scans if we have a suspicion of arthritis and meniscus tearing, because oftentimes we can successfully treat the symptoms of a meniscus tear with things that aren't surgery. So things like knee bracing, physical therapy, injections, and weight loss tend to be much more effective, or even as effective as surgery. So we'll often start with those modalities of treatment before we start considering more aggressive things. As far as injections go, again, this is something that we often hear a lot about, is injections into the knee. Probably the most common one people have heard about is cortisone. This is kind of a quick fix, so it's very effective for pain relief, but unfortunately it's pretty short lasting. And if you get multiple cortisone injections, there tends to be diminishing returns. So the first injection tends to be pretty effective, and it might last a month or two, but when we have subsequent injections, they might not last as long or be as effective. The other downside is, particularly in diabetics, it can make our blood sugars go very high. And a number of cortisone injections may actually lead to cartilage damage of the knee. So we don't want to just go on indefinitely injecting cortisone. Viscosupplementation, which people also refer to as gel injections, are a hyaluronic fluid that we can inject into your knee. It's one of the things that's normally found in your articular fluid or the joint fluid, but this one is made in a lab, and they kind of put all these bells and whistles on it so it stays in your knee for a little bit longer period of time. And it's meant to work like a lubricant and shock absorber. And if you remember when we were talking about the meniscus and the cartilage, that's what the meniscus and the cartilage really works like. So it's meant to replace that kind of function. It also works as an anti-inflammatory, and often insurance will cover this gel injection, and it could last really even up to or longer than 6 months. In patients who have it work and they find it to be effective, it can be done up to twice a year. And I have a lot of patients who will even come back, routinely every 6 or 8 months, just to have the knees topped off, as they like to say, with a gel to try to keep things calmed down. A more cutting edge and kind of interesting option that we have out there are the biologic treatments. A lot of us will hear in the media, particularly with athletes, things like stem cells and platelet-rich plasma. And particularly PRP is starting to have a lot of evidence that it might be pretty helpful in patients with early arthritis and maybe some meniscus tearing. What platelet-rich plasma is we draw your blood and we put it in a centrifuge, and then we take the part of your blood with the plasma and the growth factors and we inject that back into your knee. And that can actually work pretty effectively, and it compares pretty favorably to the other injections. Might last a little longer, might be a little bit more effective. It doesn't heal the meniscus or grow cartilage back or anything like that, but it tends to be pretty effective for pain control. Bone marrow aspirate or stem cells, pretty similar outcome. Bone marrow aspirate is where we draw bone marrow out and we can concentrate it down and inject it in. Again, it doesn't seem to grow anything back or heal any cartilage, but it may be effective for pain control. The big downside to those is insurance companies generally won't pay for that, and it tends to be out-of-pocket expenses, and it may be somewhat expensive. Moving on to another part of the body. So another common injury that we see in athletes are shoulder dislocations. The most common shoulder dislocations are the shoulder coming out the front or anterior. Often if you have a shoulder dislocation, it requires you to come to the emergency room to have that reduced or put back into place. It tends to be very painful when the shoulder is dislocated, and you aren't really able to move the shoulder when it's dislocated. Particularly in young patients who have had a shoulder dislocation, there can be a very high recurrence rate or a very high chance that the shoulder dislocates again. In patients under 20, that could be nearly everybody has multiple dislocations if they aren't stabilized with a surgery. And contact athletes are at particularly high risk. Patients who are older or masters athletes, so people older than 40 might have a high risk of rotator cuff tears with a dislocation. So even if they're able to pop it back into place, having a shoulder dislocation is reason enough to see a sports medicine specialist to have that looked at to make sure we're not missing a potentially underlying bigger injury. So as far as the treatment for it, I'd say the first time dislocation warrants evaluation for sure. The treatment of it is it's really individual, much like we talked about at the start of the presentation. So young patients, so teenagers under 20, we put a lot of thought of repairing things with a surgery just because the recurrence rate is very high. And particularly if you have multiple dislocations, that's multiple opportunities to start injuring the shoulder further. So stretching out the soft tissues that stabilize the shoulder. And multiple dislocations can also lead to some loss of bone or fracture. Surgical treatment can be done either arthroscopic or open, and recovery is about 5 to 9 months. I have a couple of little pictures on here. The first picture is a before and after of a patient who had a dislocation and had a small fracture of the socket side that we were able to repair arthroscopically. The bottom picture is a picture of a labral repair where we put the bumper back on the socket. And the pictures in the middle this is an open surgery for a patient who had a lot of that attritional bone loss, that their shoulder socket was a little narrow, and we actually move a piece of bone from a different area of the shoulder blade to the front of the socket to give us more stability. So those are some of the surgical options that are out there, and it's obviously based on every individual's characteristics. Now, while there is a lot of operative treatments, there's also conservative managements that can be quite effective with shoulder dislocation. So particularly patients that are at lower risk of having another dislocation, so maybe somebody that's in their 20s or 30s or even older, that doesn't have a rotator cuff tear, can often successfully rehabilitate a shoulder dislocation and successfully get a shoulder back to their level of activity without any problems, without a surgery. So just having a shoulder dislocation doesn't necessarily force you to have a shoulder surgery, and often we can get really good outcomes with just a rehabilitation program alone. Rotator cuff injuries. So I talked a little bit about that with the shoulder dislocations, but these are often completely separate from a shoulder dislocation. The most common type of rotator cuff injury are those that can occur as we age. So about 28% of patients over 60 have a full thickness rotator cuff tear, and that number goes up to over 65% of patients over 70. I can tell you, you probably know a lot of 70-year-olds, but not all of those 70-year-olds, or not even 65% of those 70-year-olds need to have a rotator cuff surgery. So the thing about the rotator cuff is we can have a lot of people with rotator cuff tendon tears that do poorly and need to be fixed with surgery, but we have even more people who never have a problem or can get better with physical therapy. So often this is not an acute injury. It's kind of a culmination that insidiously progresses over time. When we do have these full thickness tears, however, they don't heal on their own, and over time they tend to get bigger. Bigger tears tend to have more symptoms, and bigger tears tend to be less likely to get better with conservative management alone. What these tendons do is they basically put the ball in the middle of the socket and help stabilize the shoulder, and they help you reach out to the side of your body and work overhead. So common symptoms with rotator cuff disease are a dull, achy pain down the side of the shoulder, difficulty with overhead activities and activities where you have to reach out from in front of your body. And a lot of times people have difficulty sleeping with rotator cuff injuries. So oftentimes people kind of deal with it during the day, and what brings them into my office is they say, "Doc, I've really had a lot of trouble sleeping recently," and often it's related to this rotator cuff disease. So how do we treat it? Most often, particularly in patients older than about 60 years old, we start with physical therapy. And the majority of these patients do get better and may even resolve their symptoms completely with the therapy. The good news about the physical therapy is it tends to be effective within 8 to 12 weeks on the patients that it's going to work for. So we tend to get a pretty quick answer, and we tend to get things feeling better pretty quickly with physical therapy. For those people who don't get better, however, generally we'll recommend a surgery to repair the tendon. So what we do is we actually reattach the tendon to the bone. It's again done arthroscopically or through little poke holes around your shoulder, and the rehab is about a total of 4 to 6 months. So the first 6 weeks or so we're in a sling, but we do physical therapy and rehabilitation from about the first week or so after surgery, where we progressively start working with just range of motion alone, and then after about 3 months we start strengthening the shoulder. The one exception is generally if you have an acute injury, so say you slipped on some ice in the wintertime that 1 week where it snows, and you grab onto something and you feel a pop in your shoulder, that we might treat a little bit more aggressively, because these acute or sudden onset rotator cuff tears tend to respond better to surgery right away. I'll move on to hips as well. So hip is another potential athletic injury. Everyone's hips can impinge at some point. So what we talk about with hip impingement syndrome is usually with the hip, it's a ball and socket joint where the ball can roll around in the hip. And some people have a little bit too much bone in their hips, and that's something that develops probably during adolescence. And it's related to some of the activities we think that we're doing. So people who do a lot of high flexion sports, so things like ice hockey, offensive linemen in football, where you're doing a lot of hip flexion, it may predispose us to having this happen. And what happens in those patients is you get to a point where the hip stops rolling because you've got this little extra bump of bone and the hip starts kind of levering back and forth. And that can cause damage to some of the structures around the hip, such as the labrum and the cartilage. So what the labrum is much like in the shoulder, there's a soft tissue O-ring that goes around the hip socket that helps provide stability. And that can tear and start peeling off. And the other side of that is the cartilage can start peeling off as well. This, if it's left unchecked for a long period of time, can actually lead to arthritis. So what this is over here is a picture of an x-ray of a patient who has a big, what we call cam or bump on the femur side of their bone. And they actually had one on the other side, and this is after we'd kind of smoothed it out and given it its more normal shape. Which brings me to what we do about it. Generally, again, we'll start with physical therapy, but those patients who don't improve with physical therapy, there's actually an excellent arthroscopic procedure that we can restore function of the hip. So what we do is we actually smooth away that bone on the extra bone that you have on your femur. We can repair your labrum. And again, this does actually quite well, particularly in young patients without substantial arthritis on the hip. And patients who have had symptoms for a lesser duration of time, so less than a year or so, tends to do a little bit better than those who have had long-standing symptoms. All of that being said, patients who have more substantial arthritis, we have excellent surgery to fix arthritis, but those patients may be better served with a hip replacement. So moving on to one more topic that I just want to kind of briefly talk about, which is a more cutting edge topic, is cartilage repair and joint preservation. So we're talking not necessarily in a patient who might have arthritis, but someone who might have a pothole or a focal defect in the cartilage in your knee. And this is something that can certainly predispose to arthritis. But generally what we're able to successfully treat are things that are localized. So we don't like seeing when you've got both damage to the cartilage on your tibia and your femur and your meniscus is torn. If you've got potentially, a pothole on the femur and a meniscus tear, we can repair. Those are things that we can repair and potentially restore the joint and avoid any replacement long term in the future. So there's a couple of cool procedures that we can do for this, and some of it is a single stage procedure, some of it is multiple stage, and it all depends on any patient's particular pathology and individual demands. So one of the pictures we have here is this individual had a big area where the cartilage was damaged. He had an injury as a teenager and it kind of worsened over time. And we actually used a plug of cadaver bone and cartilage to replace the cartilage on his knee. He ended up having a knee arthroscopy for a separate reason in the future, and we saw, nice smooth joint surface, so he healed quite well. Another procedure we have is a stage procedure where we can actually take a biopsy of your own healthy cartilage and then come back a couple of months later and just basically put that in the defect, and that'll actually fill in with your own cartilage over time. And that's what's called MACI, is your matrix associated autologous chondrocyte implantation. So that's using your own cartilage to fill the defect. The downside of these procedures is they have a pretty protracted return to sport time frame, so it could really take up to a year or more before we feel comfortable letting you get back to high impact activities, because that cartilage really takes a long time to heal and kind of remodel over time to be able to do some more high demand athletic activities. So at this point, I'd like to open it up to some questions for the audience. Again, thank you all for joining. It's a pleasure to have the opportunity to be able to reach out and hopefully help offer some resources to anyone that's interested in some of these sports injuries.
Thank you so much, Dr. McCrum. That was excellent. I can attest just to your team. You were talking about the fantastic physical therapists over at Samaritan Athletic Medicine. I went through that therapy program for a shoulder dislocation and a labrum tear. I gotta say, you guys are great over there. So appreciate everything you do, and great use of the pointer. I like the digital pointer. That was awesome. Well, it is a Q&A time. We have a little less than 15 minutes. If you want to go to the chat and enter any of your questions for Dr. McCrum, we can take a look at those now. And we have, oh, great. And we have people answering. Well, here we go. And this might be a question, Bert, that we may have to get back to you on. Bert says he's a bike rider, has shoulder pain, and got physical therapy that was good. Had a friend who got a professional bike fit that was paid by for his insurance. Is it common that a bike fit is paid by your insurance? Do you have any idea, Dr. McCrum? I work a little bit on our insurance side, and I really have no idea.
To be honest, I have been asked that question a couple of times, but I think it's very dependent on specific insurance plans. Some people's actually employers through their employee assistance programs will often cover some of those things as well. But that's something that generally you'd have to reach out to your specific insurance plan to see if that would be covered.
Yeah, probably. It's probably a matter of authorization too, I would imagine. Yeah. Okay. Sorry about my dog in the background there. I don't know what he just heard. Any other questions for us before we let Dr. McCrum go here? I did want to let all of you know that you will be receiving an email as soon as this presentation is available on the Samaritan Health Services website. So if you liked what you saw today, obviously, come see Dr. McCrum or the team at Samaritan Athletic Medicine, or you can just tell your friends to check out the presentation you just watched. So you can look for that in a couple of weeks as well. Anyone else? Last call for questions. It looks like someone's writing. Here you go. Oh, softball player preventing hamstring pulls.
That's a great question. So hamstring is a very, very, very common injury. In fact, that's one of the most common athletic injuries we see. Couple important things. So we want to make sure that we have good range of motion, and it's not just stretching your hamstrings themselves. So often people who are predisposed to hamstring injuries are those of us who are a little bit more stiff in our low back and lumbar spine, might not have a great core strength. So a big part of preventing hamstring injury is just general good advice for healthy bodies. So that's good core strength. Make sure that we work on range of motion. So kind of a warm up stretching and a cool down stretching program. And then also not trying to kind of get into things too quickly. So when we're increasing our level of activity, so like at the start of the season, we want to ramp things up more gradually and make sure that we don't push ourselves a little too hard when we might not be ready completely in shape for the season.
I think that's it. I think that's going to do it, everyone. Well, thanks again for. I have a question. Something for quad. The last question under the wire here. I'm not sure if you can be more specific about what you're talking about, but maybe preventing injuries to the quad, stretches, things like that.
It looks like it's also from Danny, so I presume it's also asking about, yeah, exactly, preventing quad pulls. So very, very similar thing. So I think, stretching programs are pretty helpful. And I think a good website to find that stuff on is a website called Ortho Info. It's a website that's put on by the American Academy of Orthopedic Surgeons, and they have good little stretching regimens that you can implement for returning to sports or just to kind of incorporate into your workout program. But I think very similar things, just hamstring and quad tendon pulls in general, healthy warm up period, and then also just general strength and maintenance work, particularly focus on quad as well as your core as well as your quad and hamstring strengthening.
Another question came through while you were answering that one. Any advice on returning to exercise after PT?
Yeah, so I mean, I think that's a great question. I think our therapists here at the SAM, I think, do a great job of help trying to bridge that gap, because oftentimes, you come in and, you're having your shoulder pain or your knee pain or your hip pain. You go to therapy and you're feeling great. But then you're wondering how to get back to what you want to do and how to prevent kind of getting back in this place to begin with. So my biggest advice is to touch base with your physical therapist when you're getting ready to kind of go off and say, hey, we're done with therapy. I feel pretty good. Because they'll often give you a lot of what they call maintenance exercises or things that we should just work into our daily routines. And I hate to sound like a broken record, but I think a lot of the times it really comes down to core strengthening. And for the shoulder, a lot of stuff is periscapular or scapular exercises to really work on posture and making sure that we're not developing bad habits with the way that we move. So just getting that maintenance program can be really helpful, and carrying that forward and getting back to the activities that you want to do. IT ban, another great question. IT band is another super common injury for those of us who want to be active, most common in runners and bikers. What the IT band is, for those of us who don't know, is a big tendon that runs down the lateral or outside of your thigh. Every time you pull your knee and your hip backwards, that tendon is being told to be shorter and shorter. So as you tend to do more exercise, it tends to get more inflamed. That tendon, as it starts to get tighter, kind of wedges over the side of our hip and then the side of our knee. For IT band, I think the best stretches for those are the foam roller stretches. So you've probably seen at any sort of like workout store, like a Dick's Sporting Goods, and even some pharmacies might have these little foam rollers. They're basically foam cylinders that are a couple feet long. And what you do is you basically lie on your side and you kind of roll back and forth. And you don't want to roll on the part of your IT band that's hurting you. You kind of roll in the middle of your leg. And that's a good both warm up and cool down that you should incorporate into your exercises. When you're working on the IT band in particular, it can really take a couple of months to really get that stretched out and get those symptoms to go away. But you can generally be pretty successful so long as you're pretty diligent in sticking with that stretching.
Well, if that will do it for all the questions, everyone, again, thank you so much for attending. Thank you, Dr. McCrum. Really appreciate it.
Thank you for having me.
And we will, again, watch for that follow-up email from us. And we hope you attend another Healthy Minds, Healthy Bodies seminar really soon. Have a great